Idiopathic Pulmonary Fibrosis. Clinical features and diagnosis of IPF. Clinical features of IPF. Clinical symptoms. IPF should be considered in all adult patients with unexplained chronic exertional dyspnea, and commonly presents with cough, basilar inspiratory crackles, and finger clubbing. Unexplained chronic exertional dyspnea commonly presents with non-productive, dry, cough usually refractory to anti-cough agents. Gastroesophageal acid reflux is present in close to 90%. Symptoms such as weight loss, fever, and arthralgias are unusual in IPF and should prompt an investigation for secondary causes of pulmonary fibrosis. MJ Respiratory Care Med 2011, 183 to 788 to 824. Clinical signs. Chest auscultation, dry, and inspiratory, Velcro rails are heard, greater than 80% of patients, most prevalent in the lung bases and extend toward the upper lung zones with disease progression. Clubbing, 25 to 50% of patients. Late phases of the disease, cyanosis, cor pulmonale, accentuated pulmonic second sound, right ventricular heave, peripheral edema and other classic signs of right heart failure. MJ Respiratory Care Med 2011, 183 to 788 to 824. Clinical features, radiological. Chest radiograph. Peripheral reticular opacities, usually bilateral and asymmetric most profusely at the lung bases. Commonly associated with decreased lung volumes. Indicated if clinical deterioration occurs in order to assess progression of the disease or to identify superimposed infection or malignancy. http://www.fpf.duke.edu/diagnose.html accessed on 7th February 2012. Clinical features, radiological. HRCT pattern, essential component of the diagnostic pathway in IPF. UIP pattern, patchy, predominantly peripheral, subpleural, bibasal reticular abnormalities as well as architectural distortion and honeycombing, characteristically basal and peripheral in distribution, though often patchy. Honeycombing is common, critical for making a definite diagnosis, diameters of usually 3 to 10 mm, but occasionally as large as 2.5 cm. Presence of coexistent pleural abnormalities, for example, pleural plaques, calcifications, significant pleural effusion, suggests an alternative etiology. Mild mediastinal lymph node enlargement can be seen. The positive predictive value of a HRCT diagnosis of UIP is 90 to 100%. HRCT criteria for a UIP pattern ATS/ERS/JRS/ALAT International IPF Guidelines 2011. Honeycombing pattern. In HRCT in IPF patients. If HRCT does not demonstrate a UIP pattern, the surgical lung biopsy may still demonstrate a UIP pattern on histopathology. MJ Respiratory Care Med 2011. 183 to 788 to 824. J. Röntgenol. 2005, 185, 1531 to 1539. Clinical features of IPF pathological, surgical lung biopsy. Surgical lung biopsy is recommended in patients with suspected IPF. In any patient with clinical or radiologic features that are not typical for IPF, and if the patient's general health status permits surgery. Heterogeneous appearance with areas of fibrosis with scarring and honeycomb change alternate with areas of less affected or normal parenchyma. Fibrotic zones composed mainly of dense collagen, with scattered foci of proliferating fibroblasts, fibroblastic foci, are consistent. Transbronchial biopsy approach is not recommended as the sensitivity, specificity, number and site from where they should be obtained are unknown. UIP pattern in IPF on lung biopsy. J. Röntgenol. 2005, 185, 1531 to 1539. Histopathologic criteria for a UIP pattern ATS/ERS/JRS/ALAT International IPF Guidelines 2011. HRCT or a pathologic UIP pattern is not 100% specific to IPF. Other tests, pulmonary function tests. Patients with IPF typically reveal evidence of restrictive impairment, reduced vital capacity, VC, and TLC, by body plethysmography. Reduced lung volumes, FVC, TLC, FRC. Normal or increased FV1/FVC ratio. Pressure volume studies often yield a curve that is shifted downward and to the right, consistent with stiff, non-compliant lungs. Impaired gas exchange. Decreased gluco, PAO2, desaturation on exercise oximetry, increased AA gradient. Normal resting PFTs do not exclude IPF. MJ Respiratory Care Med. 2000 161 to 646 to 664. MJ Respiratory Care Med 2011, 183 to 788 to 824. Other tests, bronchoalveolar lavage, BAL. Most important use of BAL is in the exclusion of chronic hypersensitivity pneumonitis. Prominent lymphocytosis, greater than 40%, is seen. In IPF patients, an increase in levels greater than 5%, neutrophils in 70 to 90% of patients, eosinophils in 40 to 60% of patients, and an additional increase in lymphocytes is noted in 10 to 20% of patients. Utility of BAL in staging, or to monitor, IPF, is limited and, hence, is not routinely recommended. MJ Respiratory Care Med 2011, 183 to 788 to 824. Other tests, serological testing. Serologic evaluation should be performed even in the absence of signs or symptoms of connective tissue disease, and should include rheumatoid factor, anticyclic citrullinated peptide, an anti-nuclear antibody titer and pattern. Patients with a mildly positive anti-nuclear antibody titer and or rheumatoid factor level without any other clinical features of connective tissue should be screened for signs and symptoms of connective tissues disease, for example, arthritis, Raynaud's phenomenon, skin changes, abnormal esophageal motility. MJ Respiratory Care Med 2011, 183 to 788 to 824. Approach to the diagnosis of IPF. New ATS/ERS/JRS/ALAT International IPF Guidelines 2011, Diagnosis IPF. A. Exclusion of other known causes of interstitial lung disease, ILD, for example, domestic and occupational environmental exposures, connective tissue disease, and drug toxicity. B. The presence of a UIP pattern on HRCT in patients not subjected to surgical lung biopsy. C. Specific combinations of HRCT and surgical lung biopsy pattern in patients subjected to surgical lung biopsy. Major and minor criteria used earlier for diagnosis of IPF have been removed. American Thoracic Society, ATS. European Respiratory Society, ERS. Japanese Respiratory Society, JRS. Latin American Thoracic Association, ALAT. MJ Respiratory Care Med 2011, 183, 788 to 824. Combination of HRCT and surgical lung biopsy for the diagnosis of IPF. HRCT pattern. Surgical lung biopsy pattern, when performed. Diagnosis of IPF. 3. UIP. UIP/probable UIP/possible UIP/non-classifiable fibrosis. Not UIP. Yes. No. Possible UIP. UIP/probable UIP. Possible UIP/ non-classifiable fibrosis 1. Probable 2. inconsistent with UIP. Probable UIP/possible UIP/ non-classifiable fibrosis. Possible 2.1 Non-classifiable fibrosis. Some biopsies may reveal a pattern of fibrosis that does not meet the above criteria for a UIP pattern and the other IPs. 2. The accuracy of the diagnosis of IPF increases with multidisciplinary discussion, MDD, particularly relevant when the radiologic and histopathologic patterns are discordant. For example, HRCT is inconsistent with UIP and histopathology is UIP. Timely referral to ILD experts is encouraged. 3. Multidisciplinary discussion, MDD, should include discussions of the potential for sampling error and a re-evaluation of adequacy of technique of HRCT. In cases with an inconsistent with UIP HRCT pattern and UIP pattern clearly present on surgical lung biopsy, the possibility of a diagnosis of IPF still exists and clarification by MDD among ILD experts is indicated. MJ Respiratory Care Med 2011, 183, 788 to 824. Diagnostic algorithm in IPF. MDD, multidisciplinary discussion, UIP, usual interstitial pneumonia. MJ Respiratory Care Med 2011, 183 to 788 to 824. Differential diagnosis. Other idiopathic interstitial pneumonias, NSIP, DIP, rebuild, COP, APE. Connective tissue diseases, scleroderma, rheumatoid arthritis, polymyositis/dermatomyositis. Identifying previous exposures, asbestos, silicon, birds, metal, and wood dusts, etc., asbestosis, hypersensitivity pneumonitis. Sarcoidosis. MJ Respiratory Care Med. 2000 161 to 646 to 664.